So we're going to be talking about drug use and pregnancy, and I know that this conference is focused also on breastfeeding. I'm not an expert in breastfeeding, but I've added some additional slides to talk about breastfeeding, so we will focus on that too. So this says, I realize that this says what you need to know, and I'm guessing that there's actually more than you might need to know in these slides. And I don't know if I'm standing too close to something. Okay. But I want to also try to engage you in this large room as much as possible, so I make sure that we talk about things that are relevant to you as well. So this is me. I was already introduced. Most of my, I wear a lot of different hats. My clinical work is primarily with pregnant women with substance use disorder, and so that's where my experience comes for this talk. So I think most of you at this point, if you live at all in the United States, you recognize that there's a problem with drug use. And so a few slides kind of looking at that background. So basically this line, the blue line kind of going up, is the unintentional drug overdoses, mainly being led by opiate overdoses. And the line in green at the top is deaths from motor vehicle collisions. Ohio, unfortunately, led the way across the country as far as deaths from overdose surpassing motor vehicle collisions back in 2007, 2008. We've continued to see that number rise, even with a lot of interventions that we've done. And obviously that being in the population also means that's affecting our pregnant women and our moms. And so this slide, I think, is, there's a lot going on this slide, and some of the things I want to point out. So the red line is non-pregnant women of childbearing age. The gray line is pregnant women. And the blue line is women who are not pregnant but recently pregnant, so postpartum women. So within that first year postpartum. And so what this tells me is a couple things. So one, as a doctor, I like to believe that I'm very important and people need me. But what this tells me is that, like, actually during pregnancy, if people can quit using, whether it's alcohol, smoking, or other drugs, they do. They cut back. So if I'm seeing somebody who's pregnant, they're a pretty sick person if they can't stop using while they're pregnant. The other thing that this shows me is I think that we, in medicine, in the community, we often think of the patients I take care of as pregnant women who happen to have an addiction. And I think we need to think of these women as women who have addiction who happen to be pregnant. Because that substance use disorder, that addiction, is something that is there usually well before they get pregnant and will continue well after they deliver. And so we have to kind of look at that in the whole picture. And so why are we here? Babies. Babies are cute. Good thing about babies, Democrats, Republicans, they all like babies. But one of the things that we think about, so when babies are exposed to opiates in utero, when they're born, they can have a withdrawal from that. And so they're no longer getting that substance from the mom, whether that's prescribed or not, whether that's pain medications or otherwise, they can go through withdrawal. And so what we've seen, so these are like old numbers, so I apologize for that, but it's just sort of showing that trend that we've seen in our community also happening with our babies. So we see that the baby's experiencing withdrawal. So at my hospital, I work at Grant, in 2010 we had 60 newborns that required treatment in the NICU, compared to just 16 2 years before that. And we've continued to see those numbers really rise. And similarly, in Nationwide Children's, they saw sort of that more than fourfold increase between 2005 and 2010. And these are babies that require treatment in the NICU. There's plenty of babies who actually, not all babies who are exposed to these opiates in utero require treatment for that. So some of them, and those often don't get counted in these numbers. So I think we still don't do a great job in identifying who all these moms and babies are. And this is really looking at that data nationally. There was a study looking at, just going back and looking at what for moms and babies who are diagnosed, we saw, again, that sort of threefold increase between 2000 and 2009 across the country, and similarly that fourfold increase for moms who are diagnosed with opiate use disorder. So we're going to talk about a patient, and again, I know not all of you are in the hospital setting, so obviously, but we're going to talk about patients who might present to the hospital setting. But I'd love for you to sort of think about, and maybe help me think about how you might engage with these patients or where you might meet them. So this is a patient presents to labor and delivery. So she comes into our triage unit. She's had no prenatal care. She's about 20 weeks pregnant, so about halfway through her pregnancy. This is her third pregnancy. Her first pregnancy was full term and not uncomplicated. Her last pregnancy ended in the late first trimester with a miscarriage, and that was about a year ago. She has no other medical problems. So what is the best way to screen this patient for alcohol and drug use at the initial point of care, whether that's triage, like whether that's on labor and delivery, whether that's in a doctor's office, whether that's you doing an intake for WIC? How might we screen these moms for drug use? This is like an actual question. I don't know how we're gonna do this in a big room, but if you don't like raise your hand, I'm just gonna like look at people who are sitting in the front. Yeah. Espert, oh, warms my heart. Yeah, so screening, brief intervention, and referral to treatment. So how many of you are familiar with that term? Okay, so kudos. So yes, what are some other ways that we screen these moms for drug and alcohol use? All right, that's fine. Because you gave me the right answer, but I do want, so this is urine. We do, I think a lot of people sort of use drug tests to decide whether a mom has a substance use disorder. And that's a way to do that. But the problem is it's not a great thing. So really, a urine drug test the only thing it tells us is that a mom used drugs recently. That's it. We make a lot of assumptions based on drug tests that really we can't from a urine test, right? It doesn't tell us if that mom's impaired. It doesn't tell us her pattern of use. It doesn't tell us if her baby's gonna have withdrawal. The other thing that I know is true is this is not a parenting test, right? And so I think we have to be really careful about what this means. And so again, A+ for you, getting the right answer. So screening and brief intervention. So what we need to do is use some sort of screening tool for our patients. There's many different ones we can use, and I'll talk about a few of them. And then we want to use motivational interviewing. We're not going to go into that today, but really engaging the patient and helping them to change behavior. So there's a lot of tools for screening. Some of them are pregnancy specific and some of them are not. One of the more pregnancy specific tools for screening is the 4 Ps. Have you ever used drugs or alcohol during this pregnancy? Have you used in the past? Does your partner have a problem with drugs and alcohol, or do you have parents who have problems with drug or alcohol? We know that there's a large genetic component and also probably a social component that the parents are really important. There's other screening tools as well. So the only other one that's really specific to pregnancy is the SERP-P, Substance Use Risk Profile in Pregnancy. And actually, they put a lot of money in. One of their screening questions is really about marijuana use. The other tools are, again, not specific to pregnancy. The best screening tool, however, is the one that you use. I'm not going to tell you this is the perfect tool. The perfect tool is the one that helps you start to have that conversation with the patient. So figuring out which tool works in the setting that you're in is really helpful. All right, so we're going to go back to this patient. I know it's tiny, but I'll read it to you. I'll tell you about the patient. So you start to ask the patient questions about drug and alcohol use, and she begins to cry as she tells you that she's been struggling with Percocet for the last 11 months. She began using following her DNC after her miscarriage last year, and now she's buying or borrowing them from friends. She has been trying to cut down, but she's had a hard time because she's been having withdrawal symptoms, which for her have included abdominal cramping, diarrhea, and also the inability to take care of her older 9-year-old daughter. She's now using about 40 milligrams of oxycodone just to avoid being in withdrawal, but she was previously using up to 120 milligrams a day. She has used heroin, so she kind of told herself that's something she would never do, but she used recently because it's cheaper and injected for the first time. She's living with her husband and a 9-year-old daughter. Her husband believes that she's stopped using pills. She's smoking about half pack a day. She denies any alcohol use because her dad was an alcoholic and she doesn't want to be like him. And opiate use, as we described, she does occasionally use marijuana, but she's really denying any other drug use. So I'm going to give you a few minutes to not listen to me and talk to each other. So you look like you all are friends. But if you're not friends with the person beside you, make friends with them now. I'm going to give you a couple minutes. I want you to think about, and this is going to help me make sure I'm also giving you information that you need. I want you to tell me what are the challenges that you imagine for this patient, but also what are the challenges for you in helping to take care of this patient. So I would love to hear from people just one challenge that you came up with. So maybe raise your hand so we can get a mic to you so that we can, and if we can't get the mic there fast enough, I promise I will repeat what they say, okay? All right, so what are some of the challenges that you've seen or have?
Multi-substance abuse.
Can you say that again?
Multi-substance abuse.
Okay, excellent. So we'll touch on that a little bit in future slides, but they may not just be using opiates, right? They're using, patients that we take care of are using lots of other drugs as well. And actually there's some studies that look at women maybe more than men more likely to be polysubstance drug users, so that's really an important piece. So we have another one over there. Oh, we got one here, yeah.
Is it possible to really just do heroin once with it being so addictive?
So, right, I mean, there's a good chance that if we don't intervene that she'll use again, but I would also say she's using the oxycodone, so those are all opiates, they're all in the same category. These slides were made actually a while ago. I actually don't see many people using pills these days, right? Primarily, I don't think necessarily because of like the addiction piece, but actually more because it's cheaper, right? And it's more available. So, but that's a good point. Yeah.
And with her historian reporting, how accurate is it as far as if she says I'm doing this much, is it really double? Mm-hmm. And if she's doing these things singly, or is she actually doing them in combination? Right.
So I think, being worried about like, are we getting the full history? And I will tell you, like, you're not, right? I mean, this is that nobody wants to be a drug addict. And so it is really hard the fact that she's telling you anything at all is a big deal. And I would say the more you build that rapport with the patient and that trust, more is likely to be revealed upon further visits. But yes, that's possible that there's more to the story. Yeah.
I was going to say that she has not told her husband what's going on, so she's dealing with keeping that a secret.
Yeah. So she hasn't told her husband. So things that might bring like some concern is, is she going to be able to get treatment without talking to him about it? The other thing is there a reason she hasn't told him, right? Is that a healthy, safe relationship for her? So there's a lot that could be tied up in why she hasn't told her husband those things. And so it's important for us to address that. It's also really challenging when moms don't want to tell their significant others, even if they are supportive, because eventually they will find out. And I talk to my moms because I've been there. Like, a really bad time to tell your significant other that you're struggling with opiates is while the baby's coming out. Like, that is, like, the delivery room is not the place to have that conversation, but it happens, so.
She thinks at least I'm not an alcoholic like my dad.
Yeah, so I think that part of like saying that is that actually this is a fairly typical thing that we hear. There's actually a lot of my patients like, I'm not going to drink alcohol because my parents were alcoholics. But I think that's also where we see like there's this genetic component towards addiction. And so maybe it's not alcohol for her, but it's opiates. So.
It could be a challenge for the healthcare system to give her unbiased care. And instead of just assuming that she's drug seeking, to take her issues seriously.
Absolutely. So I think one of the things that I deal with like every day in the hospital setting and outside of it for that matter is stigma. I mean, even the words that we use to talk about our patients with substance use disorder. So one of those words, I'll bring it up because I very, very much, two things. I very, very much want you to be cool. Okay, that's important to me. So I want you to know that the cool kids don't use the word drug abuse. So abuse has a lot of like negative connotations. Also, like from a medical standpoint, the definition that we had for abuse was not actually medically helpful. So the words that we want to use would be substance use disorder. You could also use addiction. The other thing is that I've been interviewed a lot around like the withdrawal that babies have, and I've specifically asked, like, please don't use the word born addicted, and then they go ahead and put born addicted on top of the article that they write. But the reason why is that these words are important. Babies aren't born addicted. Addiction has to do with lack of control around drug use, right? And babies are having a physical withdrawal from a medication or drug that they were exposed to in utero. Babies aren't out on the street corner looking for drugs. And so that saying baby's born addicted is really negative to the mom who actually might be in treatment, and we're going to talk about that. And so it's really important the language that we use in supporting our moms, and that can be a real challenge. Yeah. Oh, sorry. We'll go there and then up here.
The mental health aspect of her loss of
previous miscarriage and the now addiction aspect of relying on.
Yeah. Right. So like the mental health, also like the grieving process, like I see that that's going to be our next topic. And I've had recently, it's not linked to opiate use, but I've had 2 moms lose babies. And so I'm really sad that I can't stay for your next session. But I do think like dealing with that, especially in a patient, like that grief, especially in a patient who already has maybe mental health issues or that substance use disorder, how do you address both?
Within a 9-year-old, it might be maybe that is a reason not to get treatment because she has to take care of a 9-year-old.
Yes, right? So one of the things that's really challenging is that our women have like extra barriers to getting care. I work on an advisory board of like a women's treatment program, and they don't have on-site childcare. I mean, that is a huge barrier for our patients. I mean, if they can't bring their kids with them and they are the primary caretaker of 3 children, like they're not coming. And so in my office, we have a group visit once a week, which is not really treatment, but it might be all that these women can do. And we make sure that like it's fine to bring your kids. And sometimes we've had to split into 2 groups now. It's gotten a little bit big, and sometimes it's a little bit of a zoo. Like for example, last week, like we had 4 patients who had babies. And so like we just have like lots of babies, which is wonderful. It's a little hard to like sort of corral that sometimes, but it's important because that's another barrier for women that maybe even men don't have.
A challenge for breastfeeding that we might have that I was thinking of is if her care provider is going to support her with breastfeeding, whether or not she's in treatment.
Yeah. So whether like her providers will support breastfeeding, absolutely. So we're going to talk a bit about the importance of like how do we approach that as providers. Like when is it appropriate to support breastfeeding? When isn't it? And so yeah, we'll talk about that. Any other challenges that you came up with? Yeah, I'll repeat.
Well, I would say that, especially in some of our small communities, being able to send them to outreach because the outreach centers are so bogged down that maybe a treatment plan for her might take months into the pregnancy.
So the challenge of just accessing treatment for that addiction,
Yeah.
right? So there's not a lot available, and I will say, women, so across the country, including in Ohio, there's lots of laws and rules that say pregnant women get priority. But actually what we know is that they don't. I mean, we have those rules and we try really hard, but they don't get into treatment any faster than anybody else. And part of that is because some people just don't do that treatment at all. So I recently became the medical director here in Columbus at Mary Haven's Addiction Stabilization Center. And I sort of said, well, now that I'm here, we're going to go ahead and accept pregnant ladies. And that is great because they can get off the street like right away. But it's also been really challenging because my nurses are like incredibly worried that they're going to deliver a baby at an addiction treatment providing site. And like, I'm like, no, that won't happen. But it nearly did. So I have to be careful because I want to continue to keep that available for our patients. So we're working through that. The nurses got one of the emergency delivery kits. I'm like, you're not going to need that. We're just going to send it right to the hospital. But so if you could just all pray that doesn't happen, that'd be great. Any other challenges? I mean, I know there are many. I'm going to actually talk a little bit about the sort of medical challenges, but please, we got time. You can interrupt me, ask questions if things don't make a lot of sense or you have other perspectives that you want to talk about. So I want to talk a little bit about what I view as sort of the risks of opiate use in pregnancy and really what I tell the moms that I'm working with when they come to see me. So one of the things that historically has been talked about, and I think is probably something we want to avoid is the risk of being in withdrawal in pregnancy. So withdrawal for our moms from opiates in particular, that's really what we're focused on right now. They can feel very sick, right? Like a severe flu, like a lot of abdominal pain, nausea, vomiting, diarrhea, cramping. So we assume, and there are some studies to show that when mom is feeling that level of stress, that there's a level of stress on the fetus. Historically, we've been worried about the risk of miscarriage in the first trimester when a mom is going through that withdrawal, and maybe in the third trimester risk of preterm delivery or fetal demise. Now, I will tell you, we don't really see this pan out in studies, okay? I do mention this because it historically is something that we mention, and I do think it's probably not a good idea to be going in and out of withdrawal in pregnancy and putting stress on a baby. But the biggest reason why, and we're going to talk about the medications, because I think it's important for you to be able to take this back and have an understanding, no matter what level you're working with, as a peer or as a nursing support or lactation consultant. to be able to talk about why it's important to be on medication. And the biggest reason is relapse, right? So without medication-assisted treatment for opiates in particular, 9 out of 10 people, maybe even more than that, will go back to using drugs, right? So this is a chronic medical disease and medication is helpful for it. Then the risk of relapse, I mean, one is that first slide, right? The risk of overdose, right? So I've had moms who've said, I really, after I deliver, I don't want to be on these medications, and we support them as best we can. And if they relapse, there's a risk of death, right? And then that baby no longer has a mom. So that's a big deal. The other thing with relapses, I mean, if they're injecting or if they're, high risk sexual behavior, risks of infection. So many of my patients also have hepatitis C, HIV, sexually transmitted infections are all part of that risk. And again, if they're using, there may be dangerous or risky behaviors going on at that same time. So domestic violence, prostitution. We mentioned earlier that they may be using other drugs. So, it may be that, if they're stable on their medication and they're not using opiates, that helps them stay away from other things. Now, the medication we'll talk about really is only for opiates, but if we can get them stable from that standpoint, maybe they're not in the environment where they're going to use also cocaine or alcohol, things like that. And even if they don't have those sort of devastating outcomes from withdrawal, there are risks of continuing to use. So that being if you're using, you're probably not taking good care of yourself, probably not getting good nutrition. So there is risk of small babies, preterm delivery, for other reasons not necessarily directly related to that withdrawal. So I want to talk a little bit about the medications that we recommend that moms be on, so that and can kind of take this back with you when you're working with these patients. So we have criteria. Again, this is sort of that, babies aren't born addicted because they don't meet these criteria. So tolerance and withdrawal are things that need to happen. They're two of the criteria that could happen for somebody to meet criteria for addiction. So one of those, if you take opiates over a period of time, you need more of them to get the same effect. When you stop them, you feel sick. But even without those, there's lots of other criteria, and many of them are around lack of control around your drug use, or wanting to stop and not being able to, or having negative consequences and continuing to use. I would say if a woman is pregnant and unable to stop, she probably meets criteria for many of these, and most likely is in that sort of severe category. So then it's, they have opiate use disorder, mild, moderate, or severe based on how many they're meeting. And if patients have opiate use disorder, I recommend that they consider medication for this. And so the two medications that we use in pregnancy for opiate use disorder, and outside of pregnancy too, one is called Methadone. The second is called Buprenorphine, or the trade name would be Suboxone. There's some other as well. So tell me, in this room, for those who are brave, what do you know about Methadone? And I will repeat, if you're not near a mic, I promise to repeat what you say. So it can be used during pregnancy, okay? What else do you know about it? Yep.
It's a maintenance drug that they use daily.
Yeah, so it's a maintenance medication that you use daily. True. So far you guys are 2 for 2. Yeah.
It fulfills it can fulfill the needs of the drug without making people high.
Yeah, so kind of it helps people feel, so we'll talk about this with both medications. So it decreases that craving, but it doesn't, when taken appropriately and as prescribed, doesn't make people feel high or euphoric. That's the goal.
Stays in the mother's and baby system longer.
Yeah, so it stays, if we're comparing it to buprenorphine, it may stay in certainly if we're comparing it to other opiates, so pain pills and heroin, it stays in the system longer. So one of the benefits of that actually, is that methadone is methadone actually is an opiate, right? So we're using an opiate to help take care of this patient's opiate withdrawal. The difference with methadone is that it has a long half-life. It sticks around for a very long time. So when a patient takes that medication, they get a dose in the morning and it lasts 24 hours. So they're not going in and out of withdrawal, so that's good from a standpoint of just maintaining stability. But they're also not having those cravings and going on, looking for drugs. They're able to be stable and ideally, get involved in more treatment be a mom, do the things that they need to do, keep their appointments and all those things as well. What else do you know about methadone? Yeah. It's an L2 drug for breastfeeding. Yay! Yeah, we'll talk more about breastfeeding at the end. All right. Any other things? What else do you know about methadone? Yeah.
You have to go somewhere special to get it.
Yes. Thank you for pointing that out. You have to go somewhere special to get it. So you have to go to a methadone clinic. And at the beginning, you have to go every day. This is important because not every community has a methadone clinic. Raise your hand if you don't have a methadone clinic in your community. Right. And so in order for those moms to get methadone, they have to drive to a community that has it every day, right? So if you live in Mansfield, your closest methadone clinic now, they used to have one, but I don't think they do, is like you might have to come to Columbus, right? So you're driving an hour, a little more, both ways. You're coming to get your medication, you're seeing a counselor, and then also you also have to have a job. Like that's a lot to ask of someone to do every day. And you're pregnant and you need to keep your prenatal care appointments. Like it's a lot. So access to care with methadone is really challenging. What else? You guys did a good job. So again, it's that full, so when we compare this to buprenorphine, this is a full opioid agonist. And what that means is that this, just like heroin and oxycodone, this is how those work as well. It goes to that opiate or pain receptor and in the brain, and it turns it on all the way, right? So from that standpoint, when we compare it to buprenorphine, it does have a little more risk if people are not taking this medication appropriately, which is part of why it's monitored so closely and that you have to go to a special clinic every day to get it. Again, our goal, like was pointed out on the other side of the room, is really to decrease those withdrawal symptoms, decrease cravings. And the other thing is that when you're on a dose of methadone, it tends to be a higher dose because they have a tolerance already, just to treat them, to keep them out of withdrawal. But then if they use a drug, methadone isn't blocking it, but like they tend to get less effect from those other drugs because their tolerance is really sort of so high and they're already getting the medication they need to treat that. So if they use, they're not going to get as much effect. So there's not as much incentive to use anyway because you won't feel it. Again, must be at a methadone clinic. We're not going to go into a lot of the other pieces of this, but it's once daily dosing, monitored very closely. So what do you know? So the other medication we use is buprenorphine, or again, trade name Suboxone or Subutex. What do you know about this medication? Yeah.
Isn't there a higher risk of abuse of this one?
So is there a higher risk of abuse with this medication? So I would say two things. So one, maybe from a standpoint of that you don't have to go to a methadone clinic. You don't have to go to a clinic every day to get it, right? So you get a prescription so you can take it with you. I would say there's a lot of hype about how this medication is abused. But I would say it could be misused, but I would say most of the time, over 90%, we have studies to support this, most of the time people who are misusing it are taking someone else's medication to avoid being sick, right? They're not typically getting high on this medication. We'll talk about the fact that this is a partial opioid, meaning it just goes to that opiate receptor and turns it on part way, so it doesn't typically cause people to feel as high or euphoric. So like quite honestly, if I'm a good self-respecting addict, I don't want to feel part way good, right? I want to feel like all the way good. So I'm not going to misuse this drug in the same way, but I might misuse it because I can't get into treatment and it's cheaper for me to get it on the street. So that is the way that it's misused. So I think it's a little different than thinking about people like injecting buprenorphine. While those things are possible, it's not typically what we see with this medication. What else do you know about buprenorphine or Suboxone? If you yell, I'll repeat it.
Would you get ill if you were to use the drug while on?
Do you know why? I know, that's the bonus. Okay, so yes, so a couple things. So it is a partial, so this is we're getting into pharmacology, which is real exciting, I'm sure, to everyone. I know it is to me. So the reason why is because we just sort of said it's a partial opioid agonist, right? So it goes to that opiate receptor and it turns it on part way, right? And the heroin or pain pills that they were using, they turn it on all the way, right? So if I just use heroin and then I take buprenorphine, which is a partial opiate, the other thing with buprenorphine is that it has what we call a high affinity for that opiate receptor, meaning that it's really sticky, right? So like it holds on real tight. So if somebody's using heroin or oxycodone, like pain pills, and I give them buprenorphine that has that high affinity but only acts part way, what I'm going to do is like displace that heroin, and I'm actually going to cause them to go into withdrawal. So I'm going to precipitate or push someone into withdrawal if I give this medication while they're actively using. So that is one of the things that's different from methadone. So I actually have to wait until the patient is in some amount of mild to moderate withdrawal before I start it. And then once they're in withdrawal, when I give this partial opiate, they feel better. It's a little bit confusing. Yes?
How does that compare to the Narcan that you would use to knock it off the receptor?
Right, so how does that compare to Narcan that we would use to knock it off the receptor or to like reverse an overdose, right? That's what the Narcan is what, or naloxone is what is a full opiate agonist. So it would work the same way, right? So if they are using, we give a full opiate agonist, so it's gonna block it all the way, and they're gonna go into withdrawal with that as well. But again, this one, once they're in some amount of withdrawal, will make them feel better and will alleviate their cravings and their symptoms. So what else do you know about buprenorphine? Yeah, or
Does it make you sweat?
does it make you sweat? So I do have some patients who complain about that as like a side effect, and so that's sort of frustrating. I mean, withdrawal can also make you sweat. I have a patient who's having a lot of like excessive sweating right now, and it might be related to her Suboxone. It's not a common, it's not everybody doesn't have that side effect. But it's also like, so here's the thing, like we don't have a lot of options for treating your opiate use disorder. Like, does the sweating worth like stopping this medication and putting you at all the other risks? And the answer for her is no, so she just sweats a lot. But I don't have there's some things we can do for that, but not a lot, so. Yeah.
Is it harder to maintain a patient on this one because of the dose and the way that they can slide back and forth between the milligrams and like what their addiction was and how they're feeling? Just some of the moms that I've talked to in WIC, you know, the ones that are on the lower milligrams, does that mean that they've done better with becoming sober kind of thing, you know what I mean?
Yeah. So it does, like, kind of like, does dose matter? Like, is it?
hard because they get the prescription and go with a certain milligram, and then is there a point where it doesn't work, and if they don't come back?
Yeah, so dosing does matter from a standpoint of we want the moms to be on the dose that they feel normal and stable on. And so one of the things that we'll talk about a little bit around sort of breastfeeding and withdrawal is that a lot of moms will say things like, well, I want to be on the lowest dose possible so that my baby doesn't have withdrawal. Unfortunately, that's not how this medicine works. Actually, the dose doesn't seem to matter. So if some moms who are on very low doses, babies still have significant withdrawal, and vice versa. Moms on fairly high doses, babies don't have withdrawal. So what we really want to focus on is like, our goal is that you, as the mom, are stable so you can get the care you need. So whatever dose that takes is what we want them to be on. What else do you know about Suboxone? Or other questions about it? Yeah.
I don't know if this is true for sure, but you might have to be on it for life.
You might have to be on it for life. So this is the challenging thing for our patients and for us as like society. It's to really think about addiction as a chronic medical disease, right? And so this medication might not be for life. It's not a perfect analogy, but I like to think of buprenorphine like I would think about insulin for a diabetic, right? So it may be that diabetic is going to need to be on insulin forever. However, right, if that diabetic loses 50 pounds, they have a supportive spouse who's willing to change their diet and exercise more, like maybe they won't need insulin forever. So when I have a patient who says to me, like, Dr. Deppen, I really want to get off this medication, my first question to them is, how is life different than when you started? Because if they're still with the same like icky boyfriend and they haven't engaged in treatment as well as we would like, if they don't have a stable, supportive environment, like their chances of doing well coming off this medication are very low. And so we have to be thinking about sort of the risks and benefits of coming off of it. And really, we also have like studies looking at functional MRIs of the brain. The longer people are on this, the more their brain actually returns to normal. And so there's not a rush to come off of this. And I think that's really hard because most of our patients are going to get pressure, even when they're doing great, from their family, from unfortunately the recovery community itself, to get off this medication, and that might be a very bad idea. So I mentioned that I have had patients I had a patient who was doing moderately well and tapered off and did overdose and die, and now, her 2 boys don't have a mom. I mean, these are big deal decisions that the patient really needs to feel prepared to do. What else do you know, or what other questions do you have about buprenorphine? Yeah. Yeah, right. Yeah, so it becomes a challenge because in some of the community support meetings like AA or NA, many of the individuals look down on people who are on medication, assisted treatment as not being clean or sober. That's super unfortunate because I think one of the things that these patients need, one thing they need is medication, another thing they need is sober social support. And so I usually, and it's more challenging, I think, in smaller communities where there's less meetings to choose from. I mean, in Franklin County, we have like 800 meetings a week. So I'm like, well, if that meeting wasn't good, go to another one. Because I want them to feel supported, but also to, staying on their medication if that's appropriate for them, but also to have that social support as well. Yeah.
You're saying government addiction.
Can you say that again?
I've been seeing a lot of things on Facebook and social media in our county, and they're calling it government addiction. Is that the long term where you have to take it for maybe lifetime? Is that what they're saying?
I don't know what they mean by that. I don't know. That sort of sounds like a conspiracy theory. I'm not I don't work for the government yet. Yeah, I don't know what that means. But I mean, I think that a lot of these things are funded through government means, right? I mean, if you're on Medicaid, they pay for you to be on these medications. But I think, I don't know. I mean, they can be on this medication long term because that's what patients need to get better. And we have a lot of evidence that this medication it works not just for pregnancy, but outside of pregnancy as well. So, yeah.
Is that long-term use, I don't know how to ask this, but does the insurance industry recognize that that's would it support someone to take it long-term?
They're getting better. Yeah, so does insurance pay for patients to be on this long-term? I think they're getting better. There was a period of time where, they're 6 months and then you're done. That's not the case anymore. And whenever we run into that, I'm happy to write a really long and snarky letter or have a phone call about, that's just not evidence-based. That's very random to say 6 months. Maybe there are people who can do well with 6 months of treatment, but most people cannot, and it really needs to be individualized to the patient.
Is this safe through breast milk?
Yeah, so maybe we'll get there, maybe we won't, but yes, you can breastfeed on buprenorphine. We'll talk a little bit more about that. How about you? Again.
I think that just not any doctor can prescribe it. They have to go to a specific pain management doctor.
Yeah, so they don't have to be a pain management doctor. Ideally, they're an addiction doc, but even still, it could actually be a primary care doc or an OB, but you have to have a special license to prescribe this medication. So, but I think the important thing, I am an addiction medicine specialist. I did a fellowship and all that. You don't have to have that level of training to prescribe this medication. You have to have an 8-hour CME, and then you have to get a license through the DEA to be able to prescribe this medication. So, so sometimes those docs, they have the training, they're fine to do it, but some of the time those docs don't know as much as others who do this work all the time. But the benefit of this is that they don't have to go to a methadone clinic every day, right? They can go to an outpatient clinic. This increases access to care. So a doctor in Marion, Mansfield, Athens, they can all, wherever you're from, doctors in that community could choose to get this license and prescribe this medication.
In our area, a lot of people do the Suboxone, and then the physicians switch into the Subutex. So what's the difference between the Suboxone and the Subutex?
You guys are the smartest crowd. Yeah, good question. And I do things differently than a lot of other folks, but we'll talk about the difference. Actually, let me see if I have a slide about it. All right, maybe I do, maybe I don't. Okay, so Subutex is just buprenorphine all by itself. Buprenorphine is the active part of the medication, whether we're prescribing Subutex, Suboxone, Zubsolv, Bunavail, all those brand names. the active part of the medication, and everything I said about buprenorphine only has to do with that part of the medication. So this medication is taken sublingually, and buprenorphine, again, is that partial opiate agonist, so it turns it on part way. It's a, quote, blocker in the fact that it has that high affinity for the opiate receptor, right? So once it's there and it's holding on, when they use something else, they don't get much effect. And so that's really important. But everything besides Subutex, so the Suboxone, Zubsolv, Bunavail, they also have naloxone. And we've mentioned naloxone because its trade name is Narcan, right? So naloxone is there, but when you take naloxone under your tongue, it does not get absorbed. So that medicine is only there to prevent people from misusing it, right? So if you were to inject buprenorphine, you might get a little more high than if you take it sublingual. If you inject buprenorphine with the naloxone, which is a full blocker, you're going to put yourself into withdrawal. So the goal there is to help with the combination product, help people not misuse this medication. Now, original studies that were done, they studied buprenorphine, the mono product, in pregnant women. So I think most people feel comfortable using that because a lot of people worry about other things getting to the baby. However, if you understand how this medicine works, the naloxone sublingually does not get absorbed. So it's not getting absorbed to mom, so it's also not getting to baby. So I feel very comfortable. It's not wrong to put moms on Subutex. I worry a little bit about Subutex's misuse potential being higher in the community. I know that naloxone does not get absorbed, so I feel very comfortable. I think we have more and more studies to show that actually it's fine for them to be on Suboxone. But some of my patients will go back to docs in their communities who don't do this work every day, and they'll tell them that, like, I'm a horrible doctor and that I should be sued. I should. I mean, maybe I am, but not because of this. This is true. You don't have to. The Suboxone is fine in pregnancy, and we have, again, more and more studies to support that. All right. And again, you have to wait until they're in some amount of withdrawal to start this, as we talked about, because we could precipitate withdrawal if they've just used in the last few hours, which is different than methadone. And so again, when we're thinking about opiate withdrawal, we've mentioned some of this, but it's, you may meet patients who are in opiate withdrawal. What does that look like? I mean, it looks like a very uncomfortable human being. But in particular, like some things that you might see, it's like having the flu. One of the other things that, one of the ways I remember things is it's like being leaky from every orifice. That's really gross. But your eyes are watering, your nose is running, you're throwing up, you're having diarrhea. So those are all opiate withdrawal symptoms. The other thing too, pupils are dilated, so you might see that. Also, they can have what we call piloerection, goosebumps. And that's where we actually get the term quitting cold turkey. It's from opiate withdrawal. It looks like little goose flesh or whatnot. The other thing too is that they're just really uncomfortable, right? So when I see a patient in my treatment facility that's in withdrawal, they might be even writhing around in bed. And that's where we get the term kicking the habit, is also from opiate withdrawal. So we have a tool to kind of monitor opiate withdrawal. That's not super important. This is a really helpful website. This is the National Alliance for Advocates for Buprenorphine Therapy. I think some of the information on there for both patients, nursing, can be really helpful. So we'll pause. We're not done. I still have you for 45 minutes. But I will pause for a second. What questions do you have thus far? Yeah. Is there a safe way to quit cold turkey? So again, if a mom wanted to come off of these medications during pregnancy, the second trimester is probably the safest period of time. We have a little bit of a buffer as far as placenta to baby size. It just makes it a better period of time. But again, there are a lot of studies we safely tapered moms off during pregnancy. Great, I believe those studies. The challenge with those studies is they don't look at what happened to mom 12 months after she delivered, right? It is great to not have a baby who has withdrawal. However, we focus a little too much on the first 18 days of life, and we don't think about the first 18 years of that baby's life, right? We want that mom to be able to be actively engaged in that child's life for, hopefully longer than 18 years, right? And so that's the piece that I think gets missed. So is it safe? Can we do it? Sure. Do I see a lot of women being successful at that who even want to do that? Because I've supported them in thinking that through. I don't see a lot of success doing that. And so that's the part where I have a hard time believing these people are 100% success. And That is just can't be true. Yeah.
Got two questions. Can you build up a tolerance to Suboxone, so you have to increase the dosage over time like other medications? Is my first question. And my second question is, you were saying that when you get Narcan, it throws you into withdrawal, which makes sense then why when we get Narcan, go out and look for drugs right away. Can you give them Suboxone after Narcan to kind of help them from doing that?
Yeah, so good. Two good questions. I already forgot your first one. Dose. Yeah, can you build up a tolerance? We don't see that so much with buprenorphine. We do see that women during pregnancy tend to need a higher dose of buprenorphine or methadone, but that probably has to do with the changes in the body and their requirements and how they metabolize. I don't know if it's because it's that partial opioid agonist. They tend to get on a dose and be stable, and actually some of them can come down, like not usually off without having trouble, but like can sometimes go down from 16 to 12 with almost no problem. So we just don't see that very often. And then that's a good question, and I'm still thinking that through because I work in an addiction stabilization center where patients can actually come directly to us after they've overdosed and been revived by EMS if they're otherwise medically stable. We still tend to wait because what can happen with Narcan is that it's real short acting, right? So, and the buprenorphine or the drugs that they may have been using last longer. So sometimes by the time they get to us, they're actually sleepy again, but don't need medication again, but we sometimes need to wait a little longer to restart it. But there's some talk about like, can we give them Narcan and then just give them buprenorphine right away? And I haven't been brave enough to try that. Some people are trying that, and so I don't know the answer. We don't have like studies about it, so I'll let you know. Call me in a year. All right, any other questions? I promise we'll have more time at the end if we don't get to. Maybe like 2 more questions. Sorry, guys. How about, we'll go here, and then we'll go there. Vivitrol. So Vivitrol is another medication-assisted treatment that we haven't talked about primarily because it's not approved in pregnancy. Now, Vivitrol is naltrexone, which sounds a lot like naloxone, which is the full agonist, and that's because it is a full agonist. They're like cousins. But naltrexone is given, or Vivitrol in particular, is given as an IM, so an intramuscular injection that lasts about a month. It is a full opioid agonist. So the benefit there is if you've given it an injection and you've blocked all those receptors, if people were to use, they're going to get a lot less effect from those drugs. Now, the challenge with Vivitrol is really starting it. So for buprenorphine, we have to wait till they're in mild withdrawal. For Vivitrol, you have to wait till they're through withdrawal, right? So you actually have to wait, like, it has to be completely out of their system. So if they're using heroin, probably needs to be 5 to 7 days. If they're using methadone or buprenorphine, it needs to be like 10 or 14 days. So that's really hard to get somebody onto that. Also, like, probably in particular, even harder if you're a pregnant patient. Again, hasn't been studied. I have some patients that I've talked to who are on Vivitrol and stable and have gotten pregnant. Most of them have chosen to come off, but I think if they're doing really well, again, we don't have studies. I think talking about the risks and benefits of staying on it with a specialist, it might be reasonable for that patient to choose to stay on it because there's probably not a lot of risk to the fetus from what we know from animal studies. But again, hasn't been studied in people, so we don't know yet. One more, and I'm sorry. Wait, back there, that's who I said. Yeah.
Okay, I have a question. So the difference in the Suboxone and the Subutex, you said that the Narcan is not absorbed sublingually.
Yeah.
So if they were to abuse it and inject it, what are the effects of Narcan on pregnancy?
So the effects are really that the mom's going to go into withdrawal, right? So what we would worry about is that stress on mom might put stress on baby. I would say probably, like, it's not good, but there's not like a problem from a naloxone standpoint, like a one-time dose causing like birth defects or things like that. I just worry about the stress on mom and baby. So again, that's also what I worry about, like on labor and delivery. If we accidentally give some of the medications we use there actually could precipitate someone into withdrawal. What can happen if we're watching the baby on the monitor is their heart rate can go down. And so usually it goes back up, but like it could cause problems in that sort of, it does seem to stress the baby. Also, a baby could be born in acute withdrawal if we precipitate that mom at the time of delivery. And so that's a little harder baby to take care of. And we'll kind of talk a little bit more about baby here, which is why we'll save the other questions for later. Sorry. So I'm going to kind of go through some of the medical stuff a little fast so that we can get to the breastfeeding stuff. But so this patient we'll go back to, she chooses to start on buprenorphine because it was too far for her to drive to get to methadone. She's doing great. She's like my gold star patient. She's going to meetings twice a week. She found good ones where they supported her. Everything is beautiful. But she wants to know, she's now 37 and 6 weeks pregnant. She wants to know like what to expect when baby gets here. Like how are we going to manage her pain? And what's going to happen with baby? Is the baby going to have withdrawal? So during pregnancy, kind of what do we do for mom and baby as far as monitoring? I would just say from a maternal standpoint, I want to see these moms more closely. So in the early in pregnancy, a lot of times we'd see moms every 4 weeks. Like that is a bad idea for these moms, right? We want to see them more regularly. Even if I'm not the doc, like I really would encourage my OB colleagues, you know, even if you're not the doc prescribing Suboxone, or even if they're not in treatment yet, if you know that they're having these struggles, take that as an opportunity to make a better connection so that they'll feel safe telling you their story. Urine drug testing, while not a great screening tool, it's a good tool for monitoring once I have them on buprenorphine and very appropriate for me to do that. And then really being involved in additional treatment. So 12-step meetings and outpatient treatment programs. Sometimes women need more than that. Fetal monitoring, there's no clear guidelines about what we should do in pregnancy, especially on a mom who's stable on methadone or buprenorphine. We don't want to over-medicalize them. There's not a lot of reason to do extra tests. We might consider more frequent growth scans. Methadone, there's maybe a slightly, like we see a trend towards slightly smaller babies, but also a lot of these moms still smoke, and so that's another reason we want to follow the babies from that standpoint. And then non-stress testing or putting them on the monitor is really only appropriate if they have some other medical problem, diabetes, hypertension. The other thing too is if I have a mom, again, we talked about buprenorphine or methadone, great for opiates, not so great for cocaine or other drugs. If I have a mom who's still using those drugs, I might start doing non-stress testing more regularly just to make sure that that fetus is okay and we don't need to deliver. So from a pain control standpoint, I'm just going to put this up here because I don't know how many of you kind of meet with, I mean, you see moms after they deliver. There's a lot of misconceptions about managing pain in patients who are on opioids. And I think this goes back to that stigma that you brought up in the back, right? How we treat the patients. There's a lot of, so when we look at this, I think there's some people who assume like their maintenance medication is going to provide pain control. But that's just their walking around, that's like they're walking around baseline, right? That's like us not giving medication, not giving anything for our pain if we're not on opioids. And so it's important to remember that. Again, a C-section is a major abdominal surgery, so not giving anything is probably not right. Number two is that we always have to be safe, and we want to be talking to our patients about the safety of these medications. But one of the misconceptions is that if I give opioids to a patient, I'm going to cause them to relapse. Actually, probably the opposite is true, right? If I just had an abdominal surgery and my doc isn't giving me opiates, and I know how to get them to feel better, like that is a bigger risk for relapse. So we want to use opioids. We want to use them safely and appropriately, but not giving them is probably not the right thing either. Number three, I'm really all about patient safety. So this one bothers me a little, but it's true. You know, patients who are who are on methadone or buprenorphine and get opiates on top of that, they're actually like in the lower risk category for having like overdose, like respiratory depression or sedation. The patients we really need to worry about are patients who've never received opiates before, right? Our 72-year-old lady who has hip surgery, she's the one that we need to worry about the most. She's at most risk for these things. But still, it's always important to be safe with these medications. And I think this number four really speaks to that stigma piece again, is that reporting pain may be a manipulation to get more pain medications. But what we know is true is that patients in the hospital setting, pregnant or otherwise, who have surgeries and a history of addiction are often given less pain medication than a patient who doesn't have that history. When in fact, because of that history and the fact that they are tolerant to opioids, they actually probably need more. So the fact that they're asking might be because they're not going to get it unless they ask. So it's kind of a difficult place for the patients to be. That's from this article, which is pretty helpful. All right, so we'll talk a little bit about newborn withdrawal. So we talked about that neonatal abstinence syndrome. So when the baby is born, they're no longer getting that medication from mom. I am focusing a little bit more on the moms who are in treatment, but this would be true for moms who aren't as well. So most of the time in most of our hospital settings here in Ohio and really across the country, we use a scoring system called the Finnegan Score. And when the score starts to go above 8, we get worried and treat that baby in whatever capacity our hospitals do that. So at my hospital, if they need medication, they go to the NICU and that they're put on morphine. Most hospitals will either use morphine or methadone to treat that withdrawal. There's a lot of looking at, do we need to do things differently? Are we over-treating these kids? And so there's a study out of Yale I don't have slides about yet, but I think we're going to start to implement at Grant, is really this idea of like, is this scoring system super helpful? So I met Loretta Finnegan. I was like, had a real fangirl moment. I'm like, oh my God, you're like Finnegan Score. You're so cool. This old lady with like bright red hair. The thing about it is that it was really used for research originally, and so we've used it as a tool. It's a good tool because it's a number. We like numbers and things that are objective, but it may not be the best tool. And we've done a lot of modifying of the tool, so it hasn't necessarily, the modified versions haven't necessarily been studied. I asked Loretta Finnegan, did you modify any of your scores? And she's like, I never modified anything. So it's just like, we don't have a lot of studies on that. So really looking at what is the goal here? What do we want babies to be doing? What do we worry about? And so Yale looked at something called eat, sleep, console, right? If a baby is eating well, they're breastfeeding well, not losing more weight than we would expect in those newborn days, if they're sleeping appropriately, and if they're consolable. If they meet all those criteria, they're probably okay. And so there's a protocol for that, and I think you might see that transition in some hospitals to really looking at this a little more holistically, like what is it is a bummer when a baby has like little tremors or shakes, but that's probably not a reason to put a baby on a medicine if they're otherwise thriving. And so I think that's kind of what we're wondering, are we over-treating these kiddos postpartum? So the Finnegan score, and these are all still true, whether or not we need to treat them or not, I think is the question. But like neurologic symptoms, so like the nerve symptoms, so they're irritable, they have like increased muscle tone. So, sometimes like you'll like lift the baby, normal babies' heads lag. These babies sometimes are already like, I have a mom who was like, oh, my baby's already holding his head up. I'm like, that's interesting. That's actually probably a sign of withdrawal, like baby's a little tight. They may have high-pitched crying. And again, if they're not consolable, that certainly is a concern. GI symptoms, and this is where I think you get the most concern, is like if they're not eating well, if they're having diarrhea, losing weight, like that. Those are concerns. Those are kids I don't want to send home until they're ready and they're thriving. And so we've talked about the two medications that we use the most in pregnancy, that methadone and buprenorphine. In 2010, Andre Jones did a study called the Mother Study where they compared the two. This was great because many of us were already using buprenorphine, and this really showed that buprenorphine, so methadone has been used much longer. It's been around much longer. So it's kind of the gold standard in pregnancy. This study showed that buprenorphine was as equivalent, so you could use either. So they really had similar outcomes for both mom and baby. Though in the baby, the buprenorphine group did require less medication when they required treatment, and they had a shorter length of stay in the hospital by about a week in the study. So methadone is not an evil medication. It's really useful for a lot of moms, but I think if a mom can do well and thrive on buprenorphine, it might be a better option from a newborn standpoint as well. And then treatment of this neonatal abstinence syndrome or withdrawal, we really want to think about, and I think this is where the sort of eat, sleep, console studies come in, is really thinking through like what are the non-medication things we can do. I really encourage moms to, we try to encourage the moms to room in, right? So when moms are with their babies doing skin to skin, things go a lot better. I also tell my moms, like, there's nothing evil that happens in the nursery. However, when the baby goes to the nursery, moms always think something evil happened, but that's because the nursery is bright, it is loud, there's lots going on, and a baby who might get stimulated is going to get overstimulated there. So if they can keep them in the room with them, keep it quiet, maybe don't have all 500 of your family members come visit, that'd be a great idea. And breastfeeding, which we'll talk about. So especially if they're on methadone or buprenorphine only, not using other drugs, that's a no-brainer. We want to encourage breastfeeding. If the baby needs medication, we do use an opioid to treat that. So typically, we're using morphine or methadone. Either is fine. My hospital went from methadone to morphine, and we decreased our length of stay a lot. But the studies don't show that. So I thought the magic was in the morphine. It's not. The other thing that we did at that same time is we went to having a standard protocol that all the docs use. So that's really important, that every day isn't a doc isn't changing the plan, that you're doing the same thing every day and nursing knows what you're doing. So that's important. There's also some studies looking at using buprenorphine in the babies to help with withdrawal, and probably more to come on that. I put this slide in here because, I recently, like I said, I had a mom whose baby did die from sudden unexpected death. But there was a concern based on a study in Finland where there was 2 deaths from SIDS from the moms who are on buprenorphine. But they've done a lot of looking back at that. There's a lot of research. It does not appear that opioids, whether prescribed or not, actually have a clear link themselves to sudden infant death. But I do think that the patients that I take care of, they have a lot of other risk factors. And I think that's important to think about, right? Many of these moms are smokers. Many of these moms don't have a lot of social support. There may be safe sleep issues in the house. And I do think those are linked with that infant death. And so we want to be paying attention to the needs of our patients. All right, so breastfeeding, I'm going to try my best. So in general, breastfeeding is good. I think I'm in a room, I don't have to say much more about that. But it's challenging when patients are misusing other drugs. And there's a lot of things that are just not really black and white. The other thing I would say is that, breastfeeding, how we do this is so different depending on where you live, right? So I think Ohio, we're kind of like middle ground kind of place. Like if we go to the East Coast, we'll look at some of the policies of hospitals. They're actually pretty strict about we're not going to let mom breastfeed. Some of them if they've used in the last trimester of their pregnancy. If you look at some of the studies out of Australia, the only criteria for not letting a mom breastfeed was if she was HIV positive or if she appeared too sedated to hold the baby. Otherwise, it was full go. It did not matter to them. So I think there's a lot of not evidence out there for what we should do. But I do think this says breastfeeding is good, right? There's a lot of reasons breastfeeding is good. There's a lot of reasons breastfeeding are good in the patients that I serve as well, right? It also helps, in addition to all of the good medical pieces for that baby, there's also a good social piece for the mom, right? That bonding with the baby. These families are at risk for neglect, and breastfeeding can help with that, right? So there's a lot of reasons that when we can support breastfeeding, we really do want to when it's safe. So we'll talk a little bit about some of the other drugs, and then we'll talk about the opioids, in particular methadone and buprenorphine. So I think my patients are also smokers, so that plays into this as well. I think it's harder. We have studies that patients who are smoking are less likely to breastfeed and also less likely to continue breastfeeding. So again, my job as a doc is also to try to help the mom quit smoking, but it can be a real challenge. There are risks from nicotine in smoking. Some of them up here we mentioned, risk of that sudden infant death, low milk supply, poor weight gain. But still, even though they have increased with smoking, if they breastfeed, it's still better than if they don't for a lot of those. So I think this is what we would do, right? Recommending breastfeeding while also supporting quitting smoking. Again, I'm not spending a lot of time here, but a lot of women, I would encourage my women not to be drinking alcohol because it's not a great idea in combination with medications I'm prescribing. But about 50% of breastfeeding women in Western countries do consume some amount of alcohol, at least sometimes. And so it's important to be able to have those conversations as well. It's discouraged during pregnancy. There's a lot less studies in lactation than in pregnancy, and knowing sort of what those outcomes are. So I think a lot of times people talk about if you're gonna drink, pump and dump or don't breastfeed for a period of time. There's this isn't important so that you know it, or that you can see it, but I think people have come up with timetables. If you have this many drinks and you weigh this much, this is how long you need to wait before you breastfeed. So I think those are reasonable things to tell patients as well. I guess the other thing I worry, I sort of and maybe this is because I deal with this all the time. The other thing I sort of think about when I have a mom, even sometimes my friends who are pregnant, will be well, how much drinking is safe in pregnancy? I'm well, if you can't, I I think there's a little bit of me that's like, if you can't stop drinking during pregnancy and you're about to have a baby, like maybe you need to think about your drinking. Like I think like you're about to be a mom, you're gonna have a lot of things on your plate. Like let's talk about your drinking a little bit more if it's that important to you. But like again, small amount in breastfeeding, we see that just being safe. Marijuana, this one gets people riled up. I think that my neonatologists and lactation consultants have nearly like, I don't know if any of my lactation consultants are in this crowd. I think like nearly they had like a drop, like, oh man, it was ugly. Neonatologists wanted to support breastfeeding in patients who are on marijuana, lactation did not. So let's talk about it. So it's the most commonly used illicit drug in pregnancy. It is present in the milk, right? So babies will get it. We don't have a lot of evidence around what that means. And this is, I think, the challenge when trying to talk to a mom about the risks and benefits of marijuana. Is we just do not know. We don't see like global intelligence scores going down. Is there a risk for impaired attention? Maybe. I think some of these studies also looking at my moms who are exposed to opiates in utero, it's really hard to tease out other factors, right? So, you know, moms who are using drugs, marijuana included, they also might, you know, what is the impact of poverty on those things as well? And so there's just a lot of factors that could play into that. So again, I think similar to nicotine, we definitely want to encourage them to not be smoking marijuana, and you want to advise them of potential like long-term effects. And then what do you do? And then I think it matters like what your policy is at your hospital. And then even then it's still challenging, right? The guidelines are great, but they don't cover every situation. So at Grant, what we have chosen to do after much deliberation, we do make the patients sign. They talk to them about breastfeeding, that there are potential unknown risks, and we have them sign like a piece of paper that states that they know those risks, or they're aware, and they'd like to continue breastfeeding, and then we do support them in breastfeeding. But I do think, and this is kind of talking a little bit more about other drugs as well, I mean, the policies that we have in the hospitals really matter. And so again, these are actually, like, I think Boston, so East Coast studies, looking initially in 2010, their breastfeeding guidelines are not unreasonable, but actually pretty stringent from a standpoint of some of the patients we take care of. You were only eligible to breastfeed if you had drug tests that were negative for 10 weeks and a negative drug test on admission, and that you were compliant with a recovery program for the 12 weeks prior to delivery, missing no more than 2 appointments. And so when they did that, only about half of the moms were even eligible to breastfeed in this group. They changed their policy just slightly, that they had to be in a treatment program, they've attended at least 50% of prenatal visits or 5 or more visits, and that they had a negative drug test for 4 or more weeks. And they were able to, then the breastfeeding eligibility went from 56% to 82%, and more of the moms initiated breastfeeding, more of the moms were breastfeeding upon leaving the hospital. So I think having these conversations in the hospital matters. Having some guidelines around this would be helpful in a community doing this work. And again, what we've talked about, like that breastfeeding is helpful for decreasing the length of stay and then for that baby and helping with their withdrawal. So we want to, when we can, support breastfeeding for many reasons. Cocaine, and I put methamphetamine, I kind of like lump the stimulants together. We don't have a lot of studies on these in breastfeeding either. But these drugs essentially are stimulants. They work quickly. They work on dopamine, which is sort of the happiness hormone. So people like get a big burst of like reward for using these drugs. In pregnancy, we worry about them. Again, we didn't talk about those. We're focused on opioids, but as a stimulant, they can vasoconstrict. They make the blood vessels shrink. So that can raise the mom's blood pressure. So things that we see in patients who are not pregnant, increased risk of heart attack and stroke at fairly young ages when using these. So for a baby too, then babies aren't getting the blood supply. So we can see things like placental abruption, preterm delivery, poor growth of the fetus. In pregnancy or in breastfeeding, there's a lot less studies, but probably not great to breastfeed while on cocaine. It will pass through the breast milk, and though there's probably limited oral absorption by the infant, but even with that, like the infants don't really have the ability to metabolize a drug like cocaine, so it's really important that they probably not get this. And like interestingly, I don't know who did this. Maybe like I don't know if anybody like when cocaine was applied to the nipple as a local anesthetic. I mean, it is a local anesthetic, but like a lot of the things we have around cocaine in babies was like based on like this, like pretty much giving the baby cocaine. And so that's bad. Don't do that. Hopefully you're not. Okay. All right. So we'll talk about opioids specifically focused on like the medication-assisted treatment. So we've mentioned some of this already. So really, like again, whether it's methadone or buprenorphine, we want the mom to be on the dose that they feel normal on. And with methadone, being on higher doses, actually the babies or the moms do better, right? They have less other drug use when they're on the doses that are probably more effective for them. But then we worry about, well, what is then the risk to baby? Is the baby going to have more withdrawal because mom's on a higher dose? And so, okay, we'll get to that in a second. Methadone and breastfeeding. So really, actually, very little of the methadone does go through the breast milk, but there is some there. But there's limited adverse outcomes. So you've kind of mentioned it as an L2. But I think, again, the small amount that they're getting, they were getting probably more of that when they were in utero. They're getting a small amount that may decrease their risk of having withdrawal symptoms. And so that's maybe helpful for these babies when moms can breastfeed. I think, again, kind of going back to we've talked about dosing on buprenorphine. Same with methadone. And so there's studies. This is not to like actually see all the studies, but with methadone, there's like you can find whatever study you want. There's some that show that there's a relationship between how high a dose the mom is on and how much withdrawal the baby has. And there's about as equal many studies that show that it doesn't. So again, I think it needs to be based on mom and what dose she needs to be on, and we will treat baby as needed. Similarly, moms on buprenorphine tend to do better at the higher doses. Again, I think they may need a little higher dose during pregnancy just because of how they metabolize. And buprenorphine and breastfeeding, same thing as methadone really. There's not a lot of great oral bioavailability. Again, in adults, like they have to take it sublingual. And babies don't tend to hold I don't know, maybe they do, hold their breast milk under their tongue for long enough, I'm not sure. But also babies are not just like little adults, so they might get some of the buprenorphine, but it's going to be a small amount, and it does improve the outcomes. And again, we don't really know like how much of the improved outcomes from withdrawal are from the breast milk versus just being that closeness and nurturing with mom. So either way, we want to encourage it. There's not a reason not to. And in this one, the data is consistent. The dose is not related to NAS, like at all. So if a mom needs a higher dose, doesn't mean baby won't have withdrawal, but we want them to be, again, on the dose they need to be on. And here are like only studies that show breastfeeding decreases the withdrawal symptoms. So when we can support breastfeeding, we want to. I mean, I think there's just a lot of myths, and I think you guys have been great in sort of thinking through like what are the things that we've heard that may or may not be true. And I think there's a lot of well, this might be good for mom, but this certainly can't be good for baby. And it really is good for both, right? It improves the mom's outcomes, like her ability to stay sober and be engaged in treatment and be engaged in life. Improves her obstetrical outcomes. So again, even though she may not have preterm delivery from the withdrawal, she's going to be able to get her prenatal care, have better nutrition, have better outcomes. And again, the baby's outcomes are better as well when mom is on a medication to help her. Again, just looking at why, a little bit more of the why to being on the things that we've already talked about. But decreasing that risk of relapse is really pretty high on my list of why moms should stay on it. Increase prenatal care. Again, decreased likelihood that they're going to use other drugs if they're stable from this standpoint. And then the babies do better from a standpoint of higher birth weights, higher gestational age at delivery. I think for me, one of the really important things, again, babies are cute, and it's so fun that they're in this room today. And it's easy to sell babies to everyone, but if we really care about these babies and our children, we really have to support the moms. And so I think that's a really important aspect of what you all do and what I hope to do as well. All right. I think we did pretty good, and we have time for some more questions.
I've heard things in the literature about using medical marijuana that doesn't have the THC content as a use in helping to keep people off opioids. And have you seen anything? Is there any future in this? Is this anything that could take the place of some of these other medications? But then I'm sure there's risks in that too. And do you think that's something that's going to be or is being studied?
I mean, I think it's something that's being studied, and I don't know the answer to that question. I don't think there's enough out there to say that it would or wouldn't work. I would be concerned because the mechanism of action is different than an opioid, and we've seen since we started using methadone in the 60s, we've seen that is the most effective for treating it. Though I'm not against using something different, but I do think we need to make sure that it's based in evidence and science as well. And at this point, we don't have enough to say. You're there.
Some of what I think what she's referring to is that they're looking at using the medical marijuana to treat pain, so that they're not using opioids in the first place, and that would be something that would be kind of more widely used instead of having people on the oxycodone or things like that.
Yeah.
Have you seen much of that?
Yeah. So again, I hesitate on a lot of that. Just like we don't have good studies. So I know we have we have medical marijuana here. We have it in other places as well. There's very few studies there's very few medical conditions that it's truly been studied in and then also shown improved outcomes. And so, again, I'm not anti-marijuana, but I am pro-evidence. And so I just want to make sure that we talk about that. So most of the evidence that we have, I think, is related to like spasticity in MS patients, and not so much just for like chronic low back pain. I don't think we have a lot of evidence that supports that at this point, but if it does show that that's more beneficial than opioids, the other challenge that we have is that there aren't a lot of great options for treating pain, right? I mean, we don't have a lot of medications that aren't opioids, even though we know opioids actually aren't the best answer for pain long term. It's really challenging to help our patients with chronic pain without more resources to do that. Yeah.
When you said that they can't start on their Suboxone until they're in withdrawal, I mean, what happens when they go for treatment? Do they have to like suffer for a few days before they can start their treatment, or how do you medically manage them? Because I think a lot of women are really afraid of going into treatment and having to go through that withdrawal before they can maybe start on the medicine.
So a couple things I would say is that if they're using on the street, they're going in and out of withdrawal all the time, right? They use at night and they're waking up in withdrawal. So like it's already happening. And they don't have to go. If we were starting Vivitrol, they'd have to go a week, right? But if we're starting buprenorphine, for the most part, we watch the there's that score. I didn't really go into detail. We kind of look at that score. It's called like a COW score, clinical opioid withdrawal score. Once they get into like mild to moderate range, we're probably pretty safe. Usually for most people, if they're using a short-acting opiate like heroin or pain pills, that's about 12 to 24 hours. So we're not talking about days of sitting around feeling miserable. Most people feel better within an hour or two of starting the Suboxone. So it's hard because they're committing to doing something different also, which is challenging and sometimes the bigger barrier. But most of them can get on it pretty easily. And honestly, a lot of times when I meet patients in the office, I call them like my self-starters. I mean, they're using it, they're misusing it because they got it from friends, but they're actually already on the Suboxone, so they've already started it themselves. So. Sorry. Okay, wait, I should go over here. I'm neglecting this side of the room. We'll be back. Okay.
What are the risks of secondhand smoke from marijuana different than the risks of secondhand smoke from cigarettes?
I'm going to go with yes, and mostly I don't know. But yeah, I mean, I have no idea. I don't know, like, if anybody actually haven't looked at secondhand marijuana smoke studies. So if those exist, send them to me. Because I just haven't looked at that, so I don't know.
All right, so I have a question more on the legal side. So you're getting these moms who are willing to go into active treatment.
Mm-hmm.
Is Job and Family Services, Child Services still getting involved for these moms?
So it's like super challenging for me. Unless I haven't, because some of them, if they're pregnant and they don't have other kids at home, no. There's no fetal protective services, right? They don't get involved until that baby gets here. So I don't have anybody to call, and that's fine. When they have older kids that are in their custody, it becomes more challenging. I don't want so I do make some judgment around, am I concerned about these kids today? What is the plan for those kids? Because I don't want my first call when I meet a mom to be to Children's Services. However, if that mom isn't able to engage, or if I ever have concerns about those kiddos acutely, I do make those phone calls. I try very hard to have those conversations with the mom up front as well. The other thing that I don't have control over, so one of the things, and that's a huge fear, and it's also a huge barrier for moms to even come to get care because they're so afraid of that. So one of the things when they come and meet me, I tell them, I'm not making that phone call today, right? I want you to get better. Let's start working together and make good steps. But I also, the other thing I tell them is when baby gets here, similarly, I don't actually think there's a reason to call Children's Services on a mom who's stable on medication. Some of my moms have been stable on it for years, but their babies can still have withdrawal. That's not necessarily a reason to call Children's Services. And I think every hospital does things differently. I think a lot of them do just make that phone call regardless. So what I tell the moms is I don't think I need to call Children's Services, but I can't control if somebody else does, right? It's our job in medicine, in the healthcare community, if we're worried about the safety of a baby at home, it's our job to call. My job, social workers' jobs, nursing job, and I don't know who's gonna be concerned and for what reason. So they could get called. But what I want you to be able to do is to be able to say, you know what, I did have this problem, and I saw Dr. Deppen on August 29th, and I got started on this medication. I'm doing this, I'm going to meetings, I have negative urine drug tests. And when you do that, the goal of Children's Services is not to take babies away from their mom, right? You just need to show them that you're doing what you need to do. And I want to make it so you feel great being honest about that. That's the conversation I try to have with them.
You've spoken to the evidence-based reasons for continued medication. We're in a rural area, and we typically see, well, not typically, obviously, but we see some moms that go through, the cycle seems to be jail, treatment center, deliver while in treatment, come home and start reusing and repeat. Mm-hmm. And is there not a mentality in some communities to continue, we've been talking about moms that we know that just don't get ongoing medication, they're discharged from treatment facilities, go forth and do what you have to do. What would you say to that? What can we do, or how do we go about helping those women?
Yeah. I think just knowing that it's a good idea to be on this medication so you can support the mom in that. But I do think there's a huge problem. So like I said, I work in the hospital system. I work at Ohio Health at Grant. And that's been most of my job, mostly been in the medical world. And in January, I started working in the addiction world. Wow, it's amazing my brain hasn't exploded to how different those systems are, right? And one of the things that I think is different is that in medicine, we look at quality, we look at metrics, we put them online so everybody can see what our infection rates are and how good our outcomes are from surgery. In the addiction world, we haven't really done that yet, right? And so there is a lot of addiction treatment that is based on how people feel or what they believe works. And that is really a problem for me. I want to change the world, but it's going to be real slow in that area. But I think, continuing to, when you know something, just sort of nudging in small ways, and it may be supporting that patient. And, it might be a good idea to find a different doctor who supports you in staying on that medication if it's working for you. And I think, the systems need to change where we are a little more open to and understand what things work and what don't. I'm not at all against 12-step programs. That is great. But if the 12-step program says you can't be on medications for mental health or addiction, that's a problem, because sometimes, usually, you need both to be successful. And so I don't have any magical answers. What community are you in? So Northwest Ohio? Okay, yeah.
So they would be going to, the center's quite far away.
center, but that's like she comes out of jail for doing jail time, then she goes there for a few weeks, then she, in 12-step, then she maybe is reunified with her child, and pretty soon we're seeing grandma with that baby because she reuses and is in that cycle. And it's just frustrating not knowing what to do for her.
I really think that the system fails our patients more than our patients fail. There's so many problems with, in particular, addiction treatment and how that works. So, just like, send me your email. We can just like start a club, like change the world. It's gonna be great. All right, maybe one more question, and then I think we have to be done. Okay, you haven't asked one, I guess.
Just had a question about back to the pain management thing. Do you have any thoughts as to why a lot of the physicians are more reluctant to prescribe the naloxone? I don't know, am I saying that right? For the just pain management part of it? Is that just because it's another opioid?
So the naloxone is or the naltrexone or naloxone, those are blockers, so those really aren't helpful for pain. And so I think when we think about pain, it's really challenging. So opiates may not actually just be the answer to chronic pain. What we find with opioids for chronic pain is that over time they actually stop working. And so the bigger problem then is like when somebody's trying to get somebody off of opioids who's been on them a long time is really challenging because one of the signs that we didn't talk about opiate withdrawal is pain, right? So it's hard to know, like, well, when I don't take my pain meds, I have more pain. Well, okay. So it might be because it was helping for their pain, but it also might be because at this point they're dependent, whether they're addicted or not may be different, but they're physically dependent on that pain medication. When they stop it, they have more pain. And so it becomes kind of a vicious cycle. So our goal is now, hopefully for most docs, is really to not start opioids until it really needs to be a last resort, or really using for acute pain is an appropriate setting, right? I have a femur fracture, I had a trauma, using them for a period of time is really appropriate, but probably that long-term use of opioids may not be beneficial really at all for patients.
So what are the pain management doctors using now for long-term?
Yeah, it's challenging. So, so some of it is physical therapy, maybe injections, maybe non-opioid medications, anti-inflammatories, like neuropathic or nerve pain kinds of medications. So, all right, I think we went over. So thank you all for your attention. It was great.